Today, we are talking about what it means to have a breast cancer diagnosis earlier than expected. I mean in your 20s, 30s or 40s. Hello, I'm Amy Dowden. I'm one of the professional dancers on Strictly Come Dancing. 2 years ago, I was unfortunately diagnosed with breast cancer. And after a mastectomy, chemotherapy, I'm very proud now to be on the other side and super grateful to be there. But now I'm on a mission to do all I possibly can to raise awareness, break the stigma, and to learn as much as I possibly can about this awful disease.
Hi, I'm Naren, one of the breast surgeons in Birmingham. I've been looking after individuals who've been touched by breast cancer for almost 2 decades, and it's a real privilege to be part of your journey and these collaborative efforts to try and improve awareness about breast cancer.
Welcome to Breast Cancer Uncovered. Being young and hearing those words, sorry Amy, it's breast cancer, isn't something you ever think is going to happen to you, especially at the age of 32. I thought I was too young to have this. How? Why? I had so many questions and so many challenges ahead.
So we're very lucky to be joined by Dr. Sacha Howell, who's a medical oncologist from Manchester. He has a real interest in women diagnosed with breast cancer at a very young age, and we'll explore some of the challenges there. We're also very grateful to be joined by Louise, who herself is very well, but did inherit a change in her gene, or a mutation, as some would call it, and what were her concerns are things that we'd like to explore. Sacha, is it okay if I say Sacha? Hi. Hi, Sacha.
Please.
So, when we're talking about breast cancer in young women, do we think we're talking about a different type of disease process compared to older women? What are the challenges for the younger population?
That's a really good question. I think the real issue with younger women is that they're diagnosed before the screening age. So actually, I think a lot of the processes of developing a breast cancer are the same. It's just that there's no screening, and therefore more commonly these cancers occur at a higher stage. So when the tumor is larger and perhaps when it's spread into the lymph nodes under the arm. So the cancers themselves are slightly faster growing, but also they tend to be presenting later because of the lack of screening.
Yeah, I was told that mine was quite aggressive, grade 3, and that was, at the time, I was told not to be alarmed because that's very common because of my age, being 32, that when you're younger, it's more aggressive.
And I guess a question for you is, what are the efforts that you are undertaking yourself? You're looking at some studies, and what was the background to why you thought that this was a necessary step to take?
Well, we know that breast cancer is the most common cause of death in young women in the UK. So between the ages of 35 and 50, it outstrips anything else, not just any other cancer. So there's already an immediate and pressing need to do something. You've very appropriately, quite rightly said that 20% of breast cancers occur under the age of 50. And in addition to that, nearly 2/3 occur in people who don't have a family history of breast cancer. So I think it's vital that we try and understand what it is that's causing these breast cancers, but also let's try and identify which women are more likely to develop breast cancer, and then we can offer them the screening that is now offered to older women at 50 years and beyond.
And what are the challenges with using the same tools like screening? So we use a mammogram. What are the challenges with using that same tool in a younger woman?
The problem, if you like, is breast density. What we mean by that is the areas of white on a mammogram. So many people who are listening will have seen a mammogram, and there are some white areas and some dark areas. The white is the fibrous and the glandular tissue in the breast. We know that in women who are over 40, the more of that there is, the higher the risk of breast cancer. But we also know that whiteness can mask cancers as they're developing. So it's quite a difficult thing for a radiologist, so, an X-ray specialist to deal with when there's a lot of density in the breast. And we know that there is more likely to be more density the younger a woman is. So women in their 30s tend to have denser breasts than women in their 40s, and certainly denser than women after the menopause, where density drops off quite dramatically.
So do we then have to adapt if we're going to be looking to try to identify younger women at risk? Do we need to adapt how we do that, given there may be some challenges with scans or mammograms on their own?
So there are two different things to that, Naren. One is the assessment of risk. And one of the things that we're doing within our study is trying to determine whether density is a strong risk factor in women in their 30s. And then the second question is mammography then an appropriate screening tool in women in their 30s, or do we need to be looking at other methods, such as an MRI scan or perhaps ultrasound?
And you've had some initial experience with exploring that question. Would you be able to sort of share with us what your recent study, the background to it, and what your initial findings may be?
Certainly, yeah. The study is called the BCAN-RAY study, and this is looking at trying to identify whether density is a risk factor in women in their 30s. We're looking at 250 women who've been diagnosed with breast cancer in their 30s. And 750 what we call control women. So these are women who haven't had a diagnosis of breast cancer. All of those 750 control women will be having a low-dose mammogram purely to assess the density. The women who've had a diagnosis of breast cancer will get their mammogram from when they were originally diagnosed, and then we can compare and see whether the density is higher in those women that develop breast cancer. The initial findings from that have actually, you'll know what it's like, Naren, in the clinics. The worry about breast screening is that we have very experienced radiologists who look at a mammogram. It's a very dense breast, and then they are more likely to say, I'm not sure if there might be a cancer there. So the woman will be called back into the clinic for further views, and that raises anxiety, understandably. And I'm very pleased to report that in the first 24 women who have come through that study, none of them have been recalled, and very reassuringly, all of those mammograms have been reported as normal. So far, so good from that perspective in the study, but clearly that's very, very early days, and we need to make sure that we are actually always in clinical studies like this not doing more harm than good, but so far, so good.
So the question, I guess, is if you now have a young lady in front of you in her 20s and 30s, what sort of, as a medical oncologist, what are the aspects of her care that you now need to put together when coming up with a plan? So, maybe exploring a little bit about things like fertility, things about wellness, tolerance to some of the treatments that you're offering?
Clearly, the first thing that we think about is looking at what are the risks from the cancer itself. So not all breast cancers are created equal. Some are, as Amy's already said, a grade 3 tumor, a bit more aggressive, and we would be thinking about chemotherapy. Obviously, you would think about surgery as well, but maybe radiotherapy, and of course many other types of treatments such as anti-estrogens or HER2 targeted treatments if it's a HER2 positive breast cancer. So there's a whole raft of different things that we can use to treat the different breast cancers. Some of those treatments come with quite severe side effects, and that's what I think you were really thinking about with that question. Fertility can be affected by chemotherapy in particular, but also the anti-estrogen treatments. The reason for that with the anti-estrogen treatments is that for young women now, we do recommend suppression of the ovaries for at least 5 years. And of course, during that period of time, one couldn't and shouldn't get pregnant. For many breast cancers, we recommend that for 10 years. And if we have a woman at 35 and we are then saying, well, we want to suppress your ovarian function and give you anti-estrogen treatments for 10 years, well, that may be the majority of the rest of a woman's natural fertility. So we have to then think about whether we might be able to stop the anti-estrogens to allow a woman to get pregnant. And there's some very nice information from a study called the Success Study, which suggests that that is actually a safe thing to do.
That's good news for me, because I am in that situation, where I had an estrogen-fed cancer and I was put into menopause. I had chemotherapy. Very lucky I responded to fertility treatment before I started chemo, so I do have 5 embryos. But, I am 34 and, a family, I've always wanted the honour of being a mum. But yet it's something that, worries me. And I know when I last spoke to my oncologist, he said we wouldn't speak about it until at least January, because he recommended at least 2 years of being, it was within the first 2 years you're at more risk of the cancer returning. But we can maybe speak after that about maybe having a break.
And I'm sure your oncologist has also said 2 years, because that's what the Success trial eligibility criteria were. So for women who'd got to 2 years after the diagnosis, everything was fine, then they could go into the study, try a break from endocrine therapy, that's the anti-estrogen treatment, and then try to get pregnant, and then just see how things go. And I suppose the message there is that don't leave it too long. Don't sort of keep trying and keep trying and keep trying, and then before we know it, we're sort of 3, 4, 5 years down the line. But certainly thinking that we'll try for pregnancy for the next 1 to 2 years, I think is entirely acceptable from the results of that study, which was very encouraging.
Thank you. We have also got lovely Louise here, and you haven't been diagnosed with breast cancer, but breast cancer is in your family and you carry the BRCA gene, am I right?
Yes, that's correct, yeah. So I've got the BRCA2 gene, which I was diagnosed with in, I believe, 2020.
So how old were you then?
22.
So very young.
Yeah.
That must have been such a whirlwind.
It was, actually, because I had just dealt with the passing of my mother from breast cancer, as well as becoming special guardian to my younger siblings. So when I found out, I always knew that I would go down the route of surgery, preventative surgery, but it kind of got pushed to the back burner for a while, just because obviously other things were more important. So it's been about 2 and a bit months now since I've had preventative surgery.
So if you don't mind me asking, what did you have done?
I had a double mastectomy and reconstructive surgery.
And how was the recovery for you?
Yeah, it was good. Honestly, I think the most challenging thing for me is going back to work and dealing with it. But overall, the recovery's been good, and I think a lot better than I thought it would go in my head, because I think approaching something like that, you do get a lot of anxiety about how things will go. You tend to sort of blow things up a lot bigger inside your head, but I think it did go a lot better than I expected it to go, yeah.
And has it put you mentally in a better position as well?
Absolutely, yeah. I can honestly say, as soon as I came out of the surgical theatre and I was just in recovery, I felt like a massive weight had been lifted off my shoulders and I didn't have to worry about anything anymore, which was the goal for me.
Yeah, I had to have the gene test as well, because my mother had breast cancer too. But I didn't carry the BRCA gene, and I can remember just being so relieved, because I'm a twin and I didn't want her to, to be going through, these big, difficult decisions, or be at a higher risk as well. But I do still worry about my twin sister after both my mum and I having breast cancer. So what is it with breast cancer? It's just, like you said earlier, it kills more women from the age of 35. What is it about the breast tissue?
So it's probably mainly down to the female hormones, estrogen and progesterone. As pretty much all women know, their breasts change every time they are about to have a period, and the breasts tend to become a bit more lumpy, a bit more tender and swollen. And what's happening there is that the cells in the breast are responding to those female hormones and dividing, and so there are more cells. Then your hormone levels drop off again, and all of those cells die. So, well, not all of them, sorry, but those ones that are being created during that process. So whenever cells divide like that, they make slight mistakes in their DNA. Our body is generally very, very good at repairing those mistakes, and actually that's what the gene BRCA1 and BRCA2 do. They're DNA repair genes. So they're repairing the DNA, and then hopefully those cells don't go wrong. Cancer is just a condition that is DNA mistakes. So you need several DNA mistakes to make a cancer. And what happens with the normal cells going through this dividing and then dying, dividing, dying, that just ultimately makes more mistakes, and that creates the cancers. And in women such as Louise, who had a BRCA2 mutation, unfortunately, the chances of making a mistake in the DNA is higher because the BRCA2, in Louise's case, isn't working.
So I guess there's a few questions to ask Louise, if that's okay.
Yeah.
What was your decision-making process about considering to have your surgery at this point in your life as opposed to maybe a little bit later on?
Honestly, for me, I think it comes down to my family history and also my mother's experience with breast cancer. So she had breast cancer in her early 30s. And I think for me, seeing what she went through, I didn't want to give breast cancer that chance to, I don't want to say get me, but I didn't want to have that chance to go through the same experience that my mother did. And I think I felt like it was more important for me to do it now whilst I'm young and I have a better chance at healing faster than opposed to later on in life when maybe I've had children and I could just have I had this image of me having surgery, having little kids running around me and being really stressed and stuff. And I just thought, I don't think I want that. I think I want it, younger, so I've got the best chance at recovery.
I think you're very brave, and yeah.
And you also.
Thank
You're so
you.
brave.
Thank you. Is this something you would recommend, having surgery younger?
So it's quite a difficult question to answer because when we're talking about an individual who's not had an event like breast cancer and who carries a gene, we tend to focus on surgery almost. There are options other than surgery. I think surgery will give the most significant risk reduction, but there are also important lessons to be learned about reducing risk through lifestyle changes. I know Sacha's also involved with risk reducing drug therapy conversations to be had in individuals. Sacha, do you have a thought about use of medication to reduce the risk of developing subsequent breast cancer?
Yeah, absolutely. So for women with BRCA2 mutations, so like Louise, the type of breast cancer is more commonly an estrogen receptor positive breast cancer, as it is in the general population who don't have mutations, and drugs like tamoxifen can reduce the risk of breast cancer. But they do that by about 35 to 40%, whereas a surgery will reduce the chance by more than 95%. So, it's a much more effective, although it's a much more effective type of risk reducing strategy, but of course it's more impactful on quality of life as well, or can be. you described it brilliantly, Louise. The weight that was lifted off your shoulders that we sometimes call the cancer bubble. You know, you can live and have breast screening every year, and but of course that then you're still living with that anxiety. Whereas when you have the surgery, it bursts the cancer bubble. Is the way that I like to describe it. Importantly, MRI screening, which is what is done for women who've got mutations in BRCA1 and BRCA2, is very, very good. And screening every year is probably as effective as a surgery in terms of cancer survival, because the cancers that are identified are very early and can be treated effectively. But of course, by having the surgery, you then don't develop the breast cancer, you don't need the treatment, and that again is impacting less on your life.
There's also something called scan anxiety, and I didn't know what that really was until now, my yearly scans or when you're waiting. And I think, anything to relieve that as well, I think will give you a better quality of life, personally, from my experience.
Yeah, we find in the breast clinic that when that anniversary comes of the yearly visit to the hospital or the healthcare professional, it's a challenging one because it dredges up all the memories of having been there, and then the scans, and then we recognise that, but I'm not sure there's.
No,
lots one can.
But at least you won't have to go through that now, the yearly wait and the scans and the waiting for the results. Do you know what I mean? You've taken that away, so by your decision.
Also, having the BRCA2 gene, I don't know if any other women out there that have the gene could relate, but you kind of feel almost like a ticking time bomb. Like you could not that you're absolutely going to get breast cancer, but when you're genetically predisposed to getting it, a lot more of a higher percentage than the average person, you do feel a lot more anxiety, and you're kind of, every time you have a scan, or you find a lump, you feel so anxious. And like you mentioned earlier, it does bring back those sort of memories, or like for me, it brings back memories of like, oh, am I going to go through the same thing that, other members of my family have gone through? So yeah, it does really help having that surgery to just take that out completely and not have that worry anymore. And to be honest, I'd never heard of the BRCA gene until I heard about Angelina Jolie having that surgery. So that was when I was first exposed to sort of what the BRCA gene is. And it did influence me, I must say, because I thought it was a very brave decision, being able to know that you could change your life with that and not get cancer, possibly. That definitely influenced me, yeah.
And I think that's what is so good about people, using their platforms to speak out, to help raise awareness, to help educate, to get people talking, breaking down the stigmas. For like yourself, it helped you to go and get tested and to make the decision ultimately, and could have led to saving your life.
Yeah, absolutely. And I find as well, going through, looking into the preventative surgeries, there isn't a whole lot of resources out there. Like, there are resources available online, but I think what's more important, or what's more helpful to see, is women who are sharing their personal journeys. So that's why I find it really important to raise awareness, because when you search on platforms such as YouTube, there aren't really that many videos of women who have gone through it personally, who can share their experiences. You can go on Google and you can find articles and things like that, but it definitely helps to have access to people who have shared their journeys. So that's why I think it's very important to raise awareness, because I don't think it's a very common gene. Do I say gene mutation, gene alteration?
I think you're allowed to say mutation.
Yeah. So I don't think it's a very common gene mutation. It's not found in a lot of people. I think I read online is it 1 in 400 women in the UK have it, or 1 in 400 people in the UK have it. So it's definitely important to raise awareness about it.
So there was an interesting trend that we observed at around the time that Angelina Jolie shared her news. And it's been coined, I guess, the Angelina Jolie effect. Sacha, have you had any experience of that effect in your clinics?
Yeah, we've published on that as well, Naren, as you know, that the number of women coming forward for risk-reducing surgery increased significantly around the time of Angelina Jolie's diagnosis, which I think was 2014. So yeah, there was a as Louise was saying, it's having that news. You may have had the information that you've got a mutation in BRCA1 or BRCA2 and deciding, you might be thinking, shouldn't I have surgery? And then when somebody like Angelina Jolie goes ahead and does that, then other people go, okay, now's my time as well, and I'd like to take up the opportunity. So we definitely saw that increase in women coming forward for surgery. And I know there was also an increase in the number of women coming through for genetic testing at the same time because of that awareness.
Do you think that women should be called up earlier for their mammograms than the age of 50 in the UK?
I think it's a really complex question to answer. There's a few elements to that. The first is the challenge of diagnosing breast cancers in younger women, and I think we had a brief conversation about the density of the breast. There's also a very important financial burden that one needs to explore. Other parts of the world will offer breast screening of women after the age of 40, and that has a burden in terms of resources. But it's a really difficult discussion to unravel. Sacha, any thoughts from your side about that?
So my opinion is that what we should be trying to do is to identify which women are at increased risk and offering them screening. So rather than just doing the whole population of women in their 30s and maybe 40s, we should be trying to identify those at increased risk and offering the screening to that population. The methods that we talked about earlier to try and identify those at increased risk can actually also identify women at very low risk of breast cancer as well. And that leads us to something called risk stratified screening. And that's really vital, because what it might mean is that we can actually reduce the amount or even stop screening altogether in those women who are at very low risk. And then you've got this balance of financial balance where you can then start to screen the women at increased risk at a younger age. So that's what we're looking at in the future, is trying an approach of risk stratified screening. And that's part of what we're trying to do in Manchester at the moment, to see whether we can get good enough at the risk prediction in the younger women.
Brilliant. Thank you so much for joining us today, Louise Yafai.
And thanks very much to Dr. Sacha Howell for giving up both your time for today. Thank you.
And if you would like any more information, please head to copperfield.org or breastcancernow.org.